And so I began my courses and I got my official certification in 2018. But you can kind of treat this stuff as you get courses. Okay. So um, from there, work experience, I worked for Kettering, or I did for a little over 6 years. And now I'm in private practice at a clinic in Oakwood called Orion Physical Therapist. So I'm kind of heading up their women's health program. And I guess I shouldn't say women, I treat men as well. And I do see kids as they come, but women would be the majority of what I see. So different diagnoses that I treat, I will treat any bladder conditions. So whether it's urgency, any type of incontinence, difficulty emptying, starting the stream, all of that I work with. Any bowel issues, whether it's constipation, diarrhea, control issues. I see a lot of pelvic pain, and whether that's abdominal, pubic bone, back, hip, vaginal, rectal, tailbone pain, anything. I tell my ladies anything from the ribs past the hips. I treat everything in there, really. Bowel stuff. So prolapse would be a big one, which we're going to get into here today. So I'll delve into prolapse a little bit later, but I see that all the time. It's very common, affecting about 50% of women. So it's a very common thing. I work with pregnancy, postpartum, I would say pre and post surgical. So whether it's hysterectomies, any bladder suspensions, hernia repairs, again, anything in that area would be something that I work with. Any core issues, so whether it's core weakness, ooh, yeah, Katie, for prolapse, that is going to be the descent of pelvic organs. So whether it's the bladder dropping, the uterus, the rectum, it could be all three, could be a combination of that. And if a woman has had a hysterectomy where they remove the uterus, the vaginal cuff, like the uterus is gone. So the top of that vaginal canal, that can also drop even after a hysterectomy. And then I've also, with hysterectomies, seen the small intestines kind of drop down as well. And so that can be a type of prolapse. So, and there's severities, right? Sometimes it's very mild. Someone has no idea it's happening. Sorry, I have a cat that's going kind of crazy right now. Anyway, sorry. So whether it's organs dropping, it could be severe pain, pressure, but we'll get into the symptoms. But bladder, bowel, uterus mainly. There are a lot of treatment options. So a slew of things that I may or may not do in a treatment session. I wanted to give like a quick rundown, not to get into the nitty gritty. I'm a pretty manual therapist, so that means I use my hands a lot. So whether it's retraining of the muscles, that could be your ab muscles, it could be your actual pelvic floor. So those sort of Kegel muscles, right? Whether it's vaginal, is it rectal? Yes, but sometimes I'll target specific areas depending on what's going on. So a lot of hands-on approach. I do look at posture and skeletal alignment, right? Or things where they should be. And then if not, we can address those. I see a lot of digestive issues, so I do a lot of belly work. It's very gentle, but effective. So of course, next is exercise. Yes, I do exercise. Kegels can be important, but they often can make things worse. So I tell all of my sports medicine, orthopedic colleagues that I've worked with to never blindly tell a woman or man to just do Kegels. Sometimes they can make everything worse. So we'll get into a little bit later as to why that could be a bad thing for us. But so exercise, I do a lot of core stabilization. Is it low back stabilization, hip? It all works together in one big, precious, like core pressure system. So we'll get into that, of course, later. So exercise, I go through dietary things to be mindful of. There are known bladder irritants, so things that can make us more urgent, more frequent, maybe more likely to leak. And then on the bowel side, there are things that can help constipation, not help constipation, help diarrhea and urgency. So sometimes we have to troubleshoot some dietary things for the ladies. Lemon water is a good one. Sorry, I just have the chat up. So as I see questions, I guess I'll just kind of go for it. I usually recommend lemon water. Mostly not lemonade, right? But if it's just a little bit of lemon in water, that can be very calming for the digestive system. And by the time it makes its way through the system to the kidneys, ureters, bladder, not an issue at all. So I love lemon water. That's a good one. So dietary stuff. And then there are some behavioral habits that I teach. So, sorry. So for my ladies who have issues with leakage, for a cough or a sneeze, we might talk about the whole squeeze before you sneeze kind of a thing. And then for urgency, if they can't quite make it to the toilet on time, there are techniques to work on calming those urges, kind of a mind over bladder situation. So behavioral stuff, I have bladder emptying techniques, bowel emptying techniques, prolapse precautions, which we'll get into when we chat about prolapse, things to not do, things so that a prolapse won't get worse. And certainly that's great for surgery as well, to help protect a surgery if that ever does occur. And then pessaries. This goes with prolapse. I don't know if anyone's heard of a pessary, but it's kind of a vaginal orthotic. They can be commonly used with prolapse. So it's something that you would actually insert vaginally to help prop up the bladder or prop up the uterus or the rectum. So pessaries can be helpful. But so I do education with my ladies about proper use. When do we take it out? How, do we clean it? What are we doing with it? So a lot of education on that front. I'm sure I'm missing something there, but yeah, that's a lot of the education. I do relaxation techniques, right? If someone is having pelvic pain, if they're so tight and tense down there that they have pain, whether it's a constant pain, I have ladies with vaginal or rectal pain when they're sitting, pain with intercourse, that is incredibly common. So I see that all the time. So I want you to picture, just as you can get knots and tension up in your neck and shoulders, you can get the same knots and tension down in those pelvic muscles. And so for those people, kegels are the exact wrong thing to do, right? They're already tense. I do not want to keep tensing something. It'll get worse. So we do the opposite. We do reverse kegels, relaxation. And then I would say modalities, right? Which would be, do we use heat? Do we use ice? I do taping techniques depending on what I'm seeing, right? I've got all the things. And then as I touched on earlier, a little bit of orthopedic stuff. So I'll look at the ribs, I'll look at the hips, the pelvis, the spine. I need everything in, this ribs past the hips. I need all that to be nice and happy together. I can't really ignore one component of that. So it's not just kegels that I care about, right? All right. So one of the topics that Julia wanted me to cover was, how do we tell the difference between if the muscles are too tight or too weak? And it can be tricky. So I want to go over some common symptoms of both. And the hard part is there's a huge overlap, which is definitely why I don't like to just go for the Kegel option, right? But so common symptoms of tension, if things are too tight, then we could see pain, of course, abdominal, pelvic, hip, back, whatever, any pain in the area. They could have difficulty initiating a urine stream. So when you've got to go to the bathroom, you may not be able to get it started. You may have issues emptying your bladder or emptying the bowel, where they're like, God, I just feel like there's more there and I can't get it out. Constipation is a common symptom of too much tension. Painful intercourse, that makes sense, right? So that's not fun. And then any urinary issues, which this is the tricky one. Frequency, so if you go more frequent, if you have more urgency, that sensation that you really got to go. And then incontinence, you can have incontinence from too much tension, because if things are tight and then you cough or sneeze, your muscles are already clenching. They have nowhere to go to help you. And so sometimes we leak because of that. So that can be tension. On the other end, if you're having significant weakness of your pelvic muscles, you still can have pain because you're unstable. So your hip pain, back pain, it could be there's research that shows a huge connection between low back pain and urinary incontinence, and it's actually a weakness of the muscles. Okay. Um, you could have all of the urgency, the frequency issues, the incontinence, the difficulty emptying the bladder. That's going to come with prolapse. So that dropping of the bladder, right? I want you to picture, I guess with the camera, it helps. If my fist is like a bladder here, we have the urethra that comes off. If your bladder is nice where it's supposed to be. With prolapse, the bladder drops, you get this sort of garden hose kink effect of the urethra, and that can make the bladder difficult to empty. Okay, so sometimes we don't empty very well. And as prolapse actually gets really severe, the incontinence can go away because of that garden hose kink effect. It's like this, it doesn't seem like it should make sense, but often they don't have incontinence. So we'll get into that with prolapse. But pressure, heaviness, that would be a common symptom of weakness. And then difficulty controlling bowel function. So I have plenty of people that I see for bowel incontinence, or maybe they have issues controlling gas. Like if they stand up and whoop, something happened, or when they're walking, they don't quite have control of gas, that would be a weakness issue. So those are the common symptoms that I would see on yourself. You know, how do you know? If you have pain with any sexual activity, I would say things are probably too clenched. That would be the obvious one. Or any of my ladies who have pain, if they have their annual wellness visit with a gynecologist, if the speculum is painful to be inserted, it should not be painful. So that's kind of how I would tell. But that's the hard part is until you have someone almost properly assess the muscles, it's kind of we're not sure. I usually err on the side of caution, but if you try kegels and they either don't work or make things worse, then I would probably go the other way. However, when I'm checking a lot of my women for kegels, I'd say probably 75% of them don't quite do them correctly. Anyway, they're usually engaging their ab muscles or their glutes, right? The butt cheek muscles or the groin muscles, or everything but the actual vaginal rectal muscles. So there's also some iffy stuff with kegels, right? And then I wanted to get into just describing prolapse, right? So I already said earlier, it could be the bladder, the uterus, the rectum. There's something called rectal prolapse, and that's actually the rectum. It's kind of a tough one, but it's like the rectum literally kind of comes out like of the rectum. So it's kind of like a telescoping. It's not so fun to deal with. But for the majority of prolapse, it's things collapsing into the vaginal canal, and you feel things in that lower abdomen vaginal region. Sometimes I have ladies that go, you know, when I go to the bathroom, sometimes they have to push something back up in. Let's see here. Oh, I see a question. Okay. Could glute clenching, be a good sign of a tight pelvic floor? Absolutely. I don't like to throw personalities with these conditions, but I myself am a stress monkey. So I would say if they're like a really stressed, anxious person, they clench their glutes all the time, they've always kind of sucked it in kind of forever, you know, that's your muscle pattern. And so odds of you being clenched vaginally are pretty good, I will say. So retraining that, letting things relax, it's okay. That would be, yeah, that's a common sign that I see. Awesome. Thanks for that. But so with prolapse, we talked about that just a little bit. Know though that prolapse, that descent of organs, is not just from weak muscles. Okay, it's not just because your Kegel muscles are weak and they're not doing their job. There are other supportive ligaments inside your abdomen that should help suspend all of your organs so they're up there nice where they should be. Your pelvic floor is really at the very bottom. It's like the last defense at keeping things inside the body. Okay, so things that can cause prolapse: constipation, so a lot of straining, I'll see ladies with a lot of heavy lifting if they've had like manual labor, or maybe they're doing a ton of garden work, a lot of heavy stuff with not good mechanics usually. That would be a common one. Pregnancy, that's a tough one, right? It's a huge change in your abdominal pressure. So everything gravity tends to go down. I will say the biggest correlation between having a prolapse and not would be the number of deliveries you have. And it's not just vaginal deliveries, C-sections, I see it all the time as well, just because when they open you up, it really tampers with what your abdominal muscles are able to do. And so if your ab muscles can't do their job, that's even more pressure down on the organs, and you could get prolapse. I think one of my youngest ladies that I saw a couple years ago, she was only 19 and she had prolapse of the bladder, bowel, and uterus, no kids. And it was from chronic constipation. So just straining like her entire life. She had really bad mechanics. So that was an interesting one, and obviously sad because there's no kids yet, but we got her in a good place. But so anyway, number of kids, did you tear during your deliveries? How big was the baby that you pushed out? How long did you push for? All of those can lead to prolapse. And then there are some normal things that happen from an aging process, right? That may predispose you to prolapse, right? So there are hormonal changes as we go through menopause and we get that decrease, that drop in estrogen. The tissues down in the pelvis tend to get a little bit thinner, right? A little bit less lubricated, and they may not be able to do their job as well. It's tough to tell though in the postmenopausal population because it's hard to say, is it muscle weakness or is it they just didn't know and this has been going on for years and then they finally sought help for it, right? So there's research to show about 50% of women could have prolapse, and then only about 10 to 20% of them actually seek treatment for it. So that's a problem, right? Let's see, I got a question here. Yeah, do I recommend estrogen cream? If there is a significant tissue irritation, dryness that I have someone, it's a complaint, whether it bothers them when they're walking, right? I have ladies that are like, it feels like a cactus is shoved up my vagina when I walk. It's so uncomfortable. Or if intercourse is painful, dryness can also, that's a common one. We will look at estrogen cream options. I also do recommend for my ladies that don't want to go a hormonal route. There are some vaginal moisturizers that I recommend for like the daily use. The problem with moisturizers is that just like for your face and body, you have to use them for them to work, versus estrogen literally is going to change the tissue. It will help plump it up. And then there's one other option to help with that kind of estrogen issue. And it's something called the Mona Lisa. It's a painless procedure that some clinics, like doctors, would do, where that can help plump the tissue up as well. It's pretty big in Europe. But I'm not going to get into that. I don't do that, but I can always refer to that. It's pretty expensive. Insurance doesn't cover it, of course, right? But anyway, so the aging process can lead to prolapse. But again, I get some ladies easily in their 80s, 90s. They've had 4 kids and there's nothing on the prolapse thing. So versus I have women, I'm 32 that are in their late 20s, 1 child, and they have significant prolapse. So it's kind of a crapshoot. I hate to say it like that, but that's prolapse. And then the symptoms with prolapse can really vary. I have some women where the doctor says this is very mild, don't worry about it. But their symptoms, they go, no, it's so uncomfortable. I can't empty my bladder. And it really causes them pain. And then on the other end, I've had ladies with pretty significant prolapse where there's no amount of kegels in the world that would fix what's going on. And they go, it doesn't bother me. And I go, okay, to each their own. I would be avoiding surgery at all costs anyway, right? Let's see. So Mary, I've got stage 3. Okay. So research can show, so does exercise help to actually lift the bladder? Research shows that proper stabilization behavioral techniques can take you up usually 1 grade. So can usually take you up to about a grade 2. Now, when I'm treating prolapse in the clinic, I try to personally not get bogged down on the stage of it, but more the symptoms. Because if you're having a stage 2, even stage 3 prolapse, but you don't have any pressure, you have no pain from it, you're emptying fine, you have no symptoms, I would say just keep doing the right things and do not pursue a surgical option. You probably won't be happy with the results. That's usually how I go about it. And I've chatted with quite a few urogynecologists and of course gynecologists and urologists in the area. And typically they don't like to do surgery unless it's symptomatic. And the reason for that is I've seen a lot of ladies after these surgeries, they went in because they just had a bladder prolapse. Aesthetically, it bothered them, which is rational, reasonable. They get it fixed and then they come out of surgery with a host of issues. This isn't all of them. Obviously, I'm biased. I'm seeing the ones where problems happen, right? But I see a lot of post-surgical women with pain just because it's trauma to the pelvis, or they come out of surgery and they have incontinence, which they did not have at all going into it. And that's that whole garden hose kink thing, right? Where the prolapse was actually giving them a false sense of continence. They were like, I wasn't leaking. And it's actually because their prolapse was so bad that now it's up where it should be. And they don't have any muscles at the bottom to do their job. Usually, if that's the case, we strengthen them up and they actually do really well. It's usually no big deal, but they're very upset, right? They're very upset with the surgeon, rightfully so, right? That now they have all this leakage. Um, but I'm not anti-surgery, right? If there are those cases where I mean, if exercise doesn't help, certainly, right? And it still bothers them, absolutely. And I've seen really great surgeries too, where I'm seeing women for other issues. I love to see women before surgery. If they know, like, hey, I'm thinking about prolapse surgery, awesome. Come in, let's get your core, like, whether it's your core, your pelvic muscles, let's get you into the best place possible to help make that a successful surgery and so that it works. Um, oh, you know what? I'm sorry, I'm reading the chat here, Julia, your question about stats in Europe versus the US. Most of our research in the pelvic world, a lot of it is European.
Oh, wow.
Yeah, because they're a bit ahead of the United States, I would say, with women's health issues and caring for their women. So a lot of our a lot of our research comes from them.
Yeah,
So
I think I heard that in Germany, well, at least I have German friends, that after after the woman had a baby, it was like mandatory to visit a pelvic floor specialist to help them recover and do things right.
yep, it's like that in the UK. France does that, where it's just kind of part of that postpartum healing,
Mhm.
where even if everything's great, which would be my preference, I'd love to see somebody once and go, you look great. Here are things to be mindful of. Go live life and
Yeah,
not mess
yeah,
it up.
exactly. So that's great, great solution. So that doesn't go into worst case scenario. And would you say that also that this is a great idea that if you see the woman before the surgery and then after the surgery, then you educate them? Because I think usually what happens is that nobody told them about alignment, nobody told them about breathing, nobody told them about core stuff. They went and did the surgery, and then things are not getting better because, again, nobody did that education. So, and basically, they went there having the same habits and same alignment, and then
Correct.
they came out of it, it's still the same, which could repeat the surgery or symptoms. So, it's like kind of finishing the circle somewhere.
I see that often. And so I try, if I'm like, okay, this is our last session before surgery, right? Normally I talk about it throughout, but we'll go through things to not, we need to protect that surgery. I want to help make it successful because often they need repairs in the future if they don't do what
Yeah.
they're supposed to do, right? Which is bothersome. I try to avoid surgery, right? But um, yeah, going through proper bowel emptying so that they're not straining because most people come out of surgery with pain medications, so they're constipated, right? So we're trying to help protect that. But I love seeing people post surgically just to be like, hey, usually the docs after they do surgery, they're like, my work is done, like you're good. So it's nice to help protect that. But I am seeing, let's see, from Jackie, how to find a therapist. So I can put a link in here as to kind of the web page that I would go to, where you can just kind of put your zip code in, and it'll give you the kind of the closest therapist to you, depending on where you are. There are two big organizations that train pelvic floor therapists. One is called Herman and Wallace. I'll type that in here. And I can send it to Julia, and you can certainly kind of disperse the information. So I did all of my training through Herman and Wallace. And then the other one is the American Physical Therapy Association. And I've done lectures and courses for them. So they also have great therapists. So you can just kind of search right there.
And you also know about the pelvic guru. So they have a big
Yes.
database. Yeah,
Yep.
that's where I usually send people to. Yeah.
Yes. Yeah. So it's pretty simple. You can always type like pelvic floor therapist, whatever your city, state, into Google, and it might come up with someone pretty close or one of those.
Yeah, but it's good to have those sources. Yeah. Okay.
Yeah. Yeah. So I'll include those. And then let's see, do genetics play a role? Yeah. So this is a good one with genetics. Yes, but the research isn't there yet to support it. So I would say there's a lot of anecdotal evidence of I see that with families where I'll get a lady, they're like, yeah, my grandma had this, my mom had this. Um, so I would say yes to genetics. Race can actually, there's known factors there that Caucasian women tend to be higher rates of it. Let me see here. What was my other one? Sorry, let's see, race was Caucasian and Hispanics. Sorry, Caucasian and Hispanics tend to be a little bit higher, and African Americans tend to be a little bit lower. Um, However, white women tend to go through a surgical repair at like 3 times the rate of other races. So like we're definitely getting, Caucasian ladies tend to be getting surgery for it. So that is a predisposing factor as well. Yeah, so genetics, race, and then we talked about the whole vaginal cesarean deliveries that can go into it, or just really poor habits such as lifting mechanics, straining with constipation, that kind of thing. So that goes into prolapse. I think that I made it through my list here. Common symptoms. So do you know you have prolapse, right? Bladder symptoms you would see, urgency, frequency, incontinence. A lot of this overlaps with what I've already stated. Difficulty emptying your bladder, maybe initiating the stream. That's a common one. Position, like leakage after you go to the bathroom, you think you're done, then you stand up and something dribbles. There might be something that kind of came out of the bladder. That's a common one that I hear. And then bowel things that I see would be incontinence, urgency with bowels, constipation, not emptying all the way. That's a common of a rectocele or like prolapse of the rectum, because you get this sort of pocket of the rectum where stool just kind of stays. And so things don't always empty well. So my ladies go, oh, like I had a bowel movement, but it doesn't feel like it's done. It's just sitting there. And that's usually when they'll kind of strain to get the rest of it out, which isn't a good habit. I would teach a different habit to help get it out easier. That's not like gross or anything. I know I hear what I'm saying, so it's not a gross thing, but it helps to protect the prolapse so it doesn't get worse. Vaginal symptoms would be pressure, heaviness. If you see or like see a bulge, literally I have ladies after they wipe, they go, ooh, there's something there, right? Like they feel it right at the vaginal opening, and that's not awesome. Usually things get worse like afternoon, evening. That would be classic prolapse where they're like, I woke up and I felt fine, but then I was on my feet all day. I was walking, or when they shower at night and things are really relaxed, then they can feel that kind of something there. Sexual symptoms would be maybe decreased sensation or arousal. Most of my ladies don't complain of it being painful during intercourse. I think they're more nervous, like nervous of their partner noticing it, than anything. But the prolapse itself usually isn't painful during intercourse, unless it's the uterus. Then you feel like your cervix is kind of getting jabbed, if that's a thing. So that's not fun. But it's hard to tell, that with the normal aging process, because decreased sensation and arousal and self-lubrication, that's pretty common as we go through menopause and we lose that estrogen. Is it prolapse? Is it that? Right. So I see that. There are similar symptoms across all the prolapse types, though. So whether it's just the bladder or just the bowel, often they'll have pretty similar symptoms. So it doesn't always seem to matter which is which. Let's see. I got a question from Katie. Let's see. So back spasms for about 9 months. Ooh, that's interesting. They mainly happen at night. My bladder's full and I'm having a spasm. So I would say really common if you're having a spasm and you don't have control of your bladder. That I hear all the time. So the spasms, do they only happen at night? Does it matter like position? I was going to say, if you want to unmute yourself, you can, Katie. Oop, hold on, you're still muted. There we go.
Yes, I will wake up at night having one. So, and it's only on the left side.
Okay.
Towards
Low
the
back?
bottom. Lower back, pretty much, yes. And I'll notice it a lot of times. I'll be laying on my left side. When I wake up and I'm having one, I'll be on my left side.
Okay. I'd be really curious about your symmetry. Like if something's a little bit off with your pelvis or your spine, like a little bit of an asymmetry can kind of cause those one muscles to kind of spasm and really tighten up. Right. And unfortunately, like where you're saying you have pain on that left lower back, that's right where from our spine nerves exit. And that area, those nerves go straight to the bowel and bladder for control. So you may be losing a little bit of control. And sometimes pain just makes our pelvic muscles like let go, almost like a fight or flight response. They're like, and there we go.
Yeah, exactly. Yeah, that happened to me yesterday. It actually happened after I had gotten up, but my bladder was really full when I got up and I was making my way to, and then I kind of just bent over a little bit just to lift the toilet lid, and then it happened. And
then it happened. And you really felt like you had to go, right? It was a very full bladder, strong urge to go to the bathroom.
Yeah, because I hadn't gotten up at all during the night.
Sure.
So as soon as I was laying in bed after I woke up, I'm like, oh, I need to get up. So
what I'd have you try is, if you have to really go to the bathroom, but you're having a spasm, would be not to pop up out of bed and make a beeline for the toilet. I'd actually have you sit on the side of the bed and just know that urges come in waves. So I would have you kind of take a breath or two, like sitting literally on the side of your bed. Try to breathe through that urge and let the bladder urge, calm and subside. And right when you go, okay, I don't feel like I have to pee so bad, then get up and calmly just go straight to the toilet. Of course, first thing in the morning, full bladder, concentrated urine, you've got to go. So don't ignore your bladder. But I have a feeling with the strong urge and the back spasm, it's a lot, and your pelvic floor is not doing what it's supposed to do. That'd be what I would start you with, not knowing your muscle.
I did have a couple x-rays last summer. And I don't remember what it was called, but I had never heard of it. All they did was recommend, some Celebrex and Flexeril, which really haven't done anything. The doctor did say, if you want to go to a physical therapist, let me know. But
okay.
Well, and Katie is local and Aubrey is local, so now you know where to go.
Exactly.
Yeah.
That's wonderful.
I'm pretty sure that you guys take major insurances, so yeah. Might have to check.
Yeah, we do take a couple of insurances, and if we don't, if insurance is like a big issue, I do know some of my old colleagues at Kettering, they take all insurances, and I could easily recommend you to one of my best friends and old colleagues in Centerville. So
Yeah, we have only two ladies out of our state. Everybody else is local.
nice. Okay.
And
Very
Aubrey is the
good.
best, as you can see.
Very good. I'm trying to think what else. I don't have a ton more other than prolapse can, we talked about lifting, straining, that's going to happen. I also see if the ab muscles aren't working appropriately. So if you've had a hernia anywhere in the abdomen, that is going to make your core, obviously your core muscles, your ab muscles are compromised. That can certainly lead to a prolapse. It's usually part of it. I also have a lot of ladies with something called diastasis recti, if anyone's heard of that. And that's common. It's our six-pack muscles, our six-pack ab muscles. It's common with pregnancy, but those muscles separate during pregnancy pretty often, and they should close back up. But if our ab muscles don't come all the way back together and they're separate, now our ab muscles architecturally aren't where they should be, and they can't do their job as effectively. Therefore, gravity, things start to drop and it's more pressure on the pelvic floor. Okay, so I see and treat diastasis recti all the time. It doesn't matter how, if your kids are 17 or whatever, I still treat diastasis all the time. It's a little easier if it's immediate postpartum, but I still treat it regardless. And then it could also be poor breathing patterns if you're breath holding. That usually comes with lifting, right? My ladies who have manual jobs.
Yeah, we just covered all of the, no, most of those things in our program. So yeah, we're working on breathing and those, I call them 4 Bs, bearing
Okay.
down, breath holding, belly pulling. And what's the fourth one, ladies? I forgot now. Put me on the spot. Anyway, there are 4. It will come to me. So we have 2 more questions. Yeah, we're doing good on time. And Aubrey has to be done at 8 o'clock because she has to take care of her son. So that was the deal.
No
we have 2
worries.
questions. And yeah, we'll just open the floor for you guys to ask more
Yeah.
questions. And yes.
I was gonna say, let's see. So, okay, seeing a couple questions here. I want to make sure I don't skip.
I think there's another question from Jennifer. That was the one that
Yes.
you mentioned, and then the rest.
So being proactive about it, I would say anytime you're lifting, if you can make things easier on yourself, not bending at the waist to pick things up, using your legs, using your hips, right? That's all good. I usually don't want you to breath hold if you're picking something up, right? But if you're already working on kind of letting the air out, if you think about your core being like a can of pop or soda, we gotta let the air out the top versus it's gonna not down. I hope you guys can't hear my child screaming in the background. Sorry. There must be something happening downstairs. So sorry if you can hear that. But so lifting mechanics are huge, engaging your core. And really, if you're already doing the belly button to spine, kind of pulling your ab muscles in, you're going to simultaneously Kegel. You may not be aware of it, but that's mechanically what happens. If you can be more mindful of it, of kind of engaging vaginal, rectal, pulling up and in, like you don't want to pass gas, right? That lift there with your core, that would be very protective. Pushing is a little bit harder on the pelvic floor versus pulling. Okay, so push versus pull, and then not straining with bowel movements would really, or like forcing your bladder to empty, like pushing hard to empty your bladder quicker. I have a lot of ladies, I feel like we just don't spend a good amount of time on the toilet because we all have 15 other things to do. Versus to generalize, guys are like sitting on the toilet for a decent amount of time and they're nice and relaxed, but that's fine. So bladder, I would say let it happen. If you're not sure if you're emptying well, I'd say lean forward a little bit, maybe rocking back and forth on the toilet. That can tip the bladder. I have ladies, they pee, they think they're done. I'd say stand up and then sit right back down. And maybe you can get another dribble or another stream out. I just don't want you to force yourself to empty, like strain to make it happen. On the bowel side, I definitely recommend putting your feet up on a step stool. It feels super strange, probably the first couple weeks that you do it. But when you put your feet up on a step stool, there's one Kegel muscle. So if my arm is like a rectum, right? There's a Kegel muscle that's like a pulley, and it helps to kink the rectum, which is good when we're standing, walking. It keeps us continent, so we're not just letting things out. But when you sit on a toilet, if you're still sitting upright, that muscle is still tight. And so how we unkink it is leaning forward, but then, sorry, feet up on a step stool. That will completely relax that muscle, straighten out the rectum. So you've got just a better mechanical advantage. You think like emptying in the woods, right? Like nice and natural. A lot of other cultures will squat, right? I visited when I was in China, they squat.
Yeah. We will be working like on our next plan. We will be working on squatty squat because we'll be working on those mechanics of counter nutating sacrum. Well,
Perfect.
yeah, so it doesn't make any sense for this word. That's okay. But I have lots of techniques for that to happen. And yes, that's what the squatty squat, squatty potty does.
Yeah. And it doesn't have to be anything high. I don't need your knees by your head or anything ridiculous. Just knees a little bit above your hips. That will help the angle. And I do this education a lot with some of my older population. If they have raised toilet seats, like the higher toilet seats, or even a bedside commode, it's great for your back and hips to get up and down, but that actually tightens that angle even more, and everyone's constipated. So it's really huge for them, for that population to get their feet up on a step stool. So bowel emptying is huge. Also, when you're on the toilet bowel movement, your breath work is going to be one of the most important things, which may seem simple and stupid. But often what I see with constipation is when you push to empty, if you don't do your proper breath work, your muscles actually kegel instead of relax. And obviously that's the opposite of what we want to happen when you're emptying. So I usually tell my ladies, relax your belly, let it big and relaxed. And then we inhale, exhale, and push. So if you're gonna push, please blow out as you do it. That will help those muscles lengthen and stretch so that they don't do the exact opposite of what you want them to do. So that can be a big one. And then there are, like, my last resort would be surgical options, right? For pessary for prolapse treatment. There are surgical options if needed. Any of my ladies, God, in their 30s, 40s, 50s, 60s, I'm just like, you're young and we don't know the longevity of a lot of these surgeries. And if you're active, I just don't love the idea of surgery unless like it absolutely is necessary. But there is that option. And then I mentioned earlier, sorry, pessaries, that sort of little thing you can insert. And when you would use a pessary is kind of all over the place. I have some women, they only use it with exercise. And then other women will kind of use it all day. So that kind of varies. Okay, so pessaries. But I guess that's it. I was like, there's a little bit of research, but I feel like I threw that in as I go. But if there's key takeaways, just think about the entire pressure system as Julia has talked about. I care about the breath work. I absolutely think we need to work on the abdominal component, the low back stabilizers, and the pelvic floor. And it's kind of like a well-functioning machine. If there's one cog in the wheel that's not doing its job, we're going to have dysfunction in that area, and that can show up in a lot of ways. So
yes, and I know another pelvic floor PT. She's out of Canada, and she does have a what does she call it? Bathroom meditation. So I can guys share that with you if you'd like, because she's, it's from that same idea. So no streaming. So she's doing it in a good way. She's very good about it, but it's very popular. So it's on the YouTube. So yeah.
Good. But any other questions for me?
Yeah, we have 6 minutes. So ladies, it's your turn.
We did it. I didn't think I was going to talk for an hour, but
you did great.
I'm okay at talking. Right?
No, you're excellent. So yes.
And I will, of course, Julia has my information. And then if anyone thinks of future questions, Julia, I mean, anyone can email me. That's not a problem at all.
Okay.
Or if anyone needs any help finding a therapist or anything like that, I would love to help. It's spreading the word is probably the best thing we can do, because these are typical taboo topics that a lot of women don't like to talk about. Maybe they're close girlfriends or something like that. But I don't like how things are normalized. Like, it's not normal to leak when you cough or sneeze. I don't care how many kids you've had. It's not normal. It's common, but not normal. So if we can make any changes, that'd be good. How to spell, hold on. Oh, pessary, got it. There we go. That's how you spell pessary. And so if you Google pessary, you're gonna get like an interesting image. Okay, there's lots of shapes, lots of sizes. And so there's a little bit of a trial process for what works for some women. And for the pessary, if it's too small, it's gonna fall out. That's useless, okay? If it's too big, it can be uncomfortable, and a pessary should never be uncomfortable. I like to think about, if a tampon or a menstrual cup is incorrectly, we shouldn't feel it. It's just there. That's how a pessary should be. So never painful. But yeah.
Well, in talking about surgeons and all of that, and how there is still a disconnect, because I have a friend and she heard me doing Facebook Live with another lady from New York, and she contacted me, and apparently she had to do a prolapse surgery with a surgeon. So, and when she was talking to him afterwards, he had no idea about pelvic floor physical therapists.
Oh.
And she was telling him about me, that I work with pelvic floor physical therapists. And that's what she said. He was like very, very surprised and impressed. And he said, yes, I need to know some. I'm like, yeah,
Awesome.
you do. So, because he has no transitional phases after that. By the way, she's coming to see you soon.
Awesome.
Yeah. And she's going to mention your name to him because she's going to see him in April. So yeah, I did send the information, and she was saying, is it okay if I tell him that, send the people to her? So yeah, it's just such a huge disconnect, and it's not right.
It's a little bit frustrating for the specialty. We try to get out to as many docs to get on their radars. I think some of the younger docs are getting more of it in their residencies and their schooling. Like urogynecologists, they tend to know what we are, but if it's urologists, just OB-GYNs, they may not, and certainly not general surgeons. A lot of family docs don't know about it. So
yes, yeah.
We'll get there, hopefully.
And educating and learning, yes.
Very good. Well, reach out if any of you have questions in the future. Super open.
Is somebody talking, or yeah, questions? No? Last one. Well, that's it. We're going to be closing the show.
Julia, can you hear me?
Yes.
Okay, I know we're totally ready to close. I have one really fast question. Aubrey, would you recommend like an annual visit with a core pelvic floor PT just to like get a checkup?
Oh, that is a good one. I would love if that's where we were in society, for just a quick wellness, just to make sure this is where you're at, this is what you've been doing. Yes, things are going great, or do we need to tweak things and change your program? Absolutely. I love that for a wellness maintenance kind of standpoint. Yeah, that'd be great.
Yes, great question. All right. Thank you, ladies, for joining, and so much. Thank you, Aubrey, for showing up and educating us. You've been excellent and helpful, and yeah, so we'll stay in touch. If you guys have any questions, let me know. I can post her link again, or she just posted here in the comments. Whoever is local, yeah, visit your local pelvic floor PT. Yes. Absolutely. And keep up a good work, because strengthening your entire body is going to relieve the pressure off your pelvic floor. And just like what I learned about bunions, because that's what people ask, like, is it genetics? Is it genetics? Is it genetics? Well, yes, it could be, but if you know it's genetics, could you do anything possible to change your habits and learn anything you can not to make that happen? So because bunions can also be biomechanical, you know, pelvic floor prolapse can be biomechanical. And I mean, yeah, genetics are there. Like, you know, my mom had bunions, and by this age, she already had her surgery. But because I knew that, I've been working on not having that surgery. So my bunions are now growing. So just that, you know, we have the power, we have the knowledge, we have the experts. So that's always good to just work to be as proactive as we can.
Julia, I would love for you to talk more about bunions then. I didn't know there was something you could do to help with that. I have them.
Feet is my specialty, and feet are related to pelvic floor quite a bit. So if your feet are weak, guess what? The forces are going to be taken somewhere else and pulling and whatever. Yeah.
Okay.
But anyway, so yes, thank you so much. I hope your son is going to be happy to see you soon. And do you sing a lullaby for him?
It'll probably 2 or 3 books 7 times. He's the master of procrastination for bedtime. So
okay. Yay. Well, thank you, ladies. Have a
Thank
good
you.
night. We'll stay in touch. Thank you so
Good
much.
night.
Bye.
Thank you. Bye.
She's so scared.
I'll just stay here, say goodbye. If you guys have any questions or want to address something, I can stay. Otherwise, we'll be in touch. And Katie, well, yeah, she already gone. Bye, Amanda.